Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the second episode of brand new Optometry Series 2.0. I'm very happy to welcome my team members, Ms. Anshika ma'am and Ms. Meenakshi. Hi, both of you. So the pillars, two more pillars of Optometry Series. Thank you so much for joining today also. Anshi ma'am, so over to you. What is today's topic and who is our moderator, ma'am?
Thanks, Gomati. I would first like to welcome Suriya. Thank you, Suriya, for being able to join us today. Suriya is a faculty at Vinayaka Missions, and our topic today is about corneal pathologies. As you already mentioned, we have started with a new session that is 2.0. So, as an optometrist, it's not only important for us to just know refraction, but to go beyond and understand what are the diseases that is there and how we can refer when it is required, or how we can help the patients with teleophthalmology or teleoptometry and co-manage the cases. So it's very, very important that we start with the disease aspect also. So today's topic, we start with understanding corneal pathologies. So over to the MC to introduce our moderator for today.
Yes, good evening everyone. I am Madhavan, a first year Bachelor of Optometry student at Dr. Agarwal's Institute of Optometry. It gives me great pleasure to warmly welcome today's moderator, Mr. Suriya Alagupandian sir, Assistant Professor at the School of Allied Health Sciences, Vinayaka Missions Research Foundation, Salem. Sir has received multiple accolades, including first prize in case presentation at the SRM World Sight Day 2024 celebrations, National Quiz, Jury's Choice Award for Photography, and runner-up in the videography competition conducted by LV Prasad Eye Institute in 2020. He is also the proud recipient of the Academic Excellence Award for 2023 and 2024. In addition to these, he has won awards in various poster, debate, and drawing competitions, and has also published a poster in the TNOA Journal of Ophthalmic Science and Research. We are truly honored to have you with us as today's moderator, sir. Welcome, sir. And now I am happy to invite Ms. Nivya Fabi, a second-year master's student in optometry at Dr. Agarwal's Institute of Optometry. Ms. Nivya, please start your presentation. Thank you.
Yes, Madhavan. Thank you, Madhavan. Good evening, everyone. Myself, Nivya Fabi, master's from second year. My topic is corneal disease. So basically, cornea is a avascular, transparent, which covers 1/6 of the anterior fibrous coat of the eyeball. It consists of many layers like epithelium, bounce-man layer, stroma, predecimal membrane, and the endothelium. Now we are going to do the sign of corneal disease. In this presentation, we are going to discuss about the various pathological condition of the corneal disease. So first, superficial signs. Superficial signs involves epithelium to the bounce-man layer. So first, punctate epithelial erosions, punctate epithelial keratitis, subepithelial infiltrates, filaments, superficial punctate keratitis, epithelial edema, superficial neovascularization, and pannus. Punctate epithelial erosions. They are tiny epithelial defects. They can be seen with the staining of a fluorescent and rose Bengal. Causes can be depending upon the various lesion location like superior, interpalpable, inferior, diffuse, and central. Punctate epithelial keratitis, granular opalescent epithelial cell, focal intraepithelial infiltrates. Causes occurs due to the infectious adenoviral, herpes simplex virus, molluscum, etc., and miscellaneous and keratitis and drug toxicity. Subepithelial infiltrates, a deep and non-staining inflammatory infiltrates which can be seen on the naked eye, and it causes due to the viral or the chlamydial infection. Superficial punctate keratitis, they are non-specific star-like morphology, filaments or strands of mucus, adherent epithelium, which is associated with the dry eye or the superior limbic keratoconjunctivitis. Epithelial edema. This condition is seen in the raised intraocular pressure or the endothelial issues and bullae in the moderate or the severe cases. Superficial neovascularization. They are the impression of the corneal surface vessels in response to the decrease in the oxygen level and inflammation. And pannus or the superficial neovascularization with subepithelial fibrosis. So deep signs includes from the layer of the stroma to the endothelium. Infiltrate yellow, gray, whitish opacities in the anterior stroma, indicates of infections and inflammation, and use of the pedal to differentiate the infection from steroid. P for pain, endothelial defect, discharge, anterior chamber changes, and the location. Ulceration, tissue excavation with epithelial defect, and often bacterial or the fungal origin. Melting, stromal disintegration is seen in progressive bacterial or the fungal ulcers. Vascularization, deep vessels chronic inflammation, ghost vessels seen after regression, and lipid deposition may follow chronic inflammation. This is the ulceration and deposition with vascularization. And folds in deciment membrane. It is caused by corneal edema, decimatosely, bubble-like herniation of deciment membrane into the cornea. It indicates a full thickness corneal defect plugged by deciment membrane, break in deciment membrane, corneal enlargement, example HAP strain in infantile glaucoma, deformation, example keratoconus and birth trauma. Sheetal test, this is a test in which we can detect the aqueous leakage from the anterior chamber. 1% or 2% of the fluorescence is instilled in the ocular surfaces. If the color changes from the dark orange to the bright yellow, it indicates of the leakage of the aqueous from the anterior chamber, which is resultant positive. These are the congenital abnormalities of cornea, megalocornea, microcornea, cornea plana, and corneal opacity. Megalocornea. Horizontal diameter of the cornea will be usually 10 mm in birth, and for the adult, it will be 11.7 mm by 2 years of age. And megalocornea is labeled when the horizontal diameter of the cornea of adult is more than 13 mm or greater after the 2 years of age. Cornea is usually clear and normal thickness and vision is normal. This condition is not progressive, and it is also associated with various systemic associations like Marfan's, Apet, Ehlers-Danlos, and Down syndrome. Differential diagnosis includes ophthalmos. In this condition, IOP will be raised in eyeball from center to the peripheral hole and clouding and deciment tears. Keratoglobus, in this condition, there is a thinning and excessive progression of the cornea, which seems enlarged, but diameter will be usually normal. Microcornea. In microcornea, the horizontal diameter will be less than 10 mm since birth. This condition may occur as an isolated anomaly or in association with nanophthalmos, normal small eyeball, or microphthalmos, abnormal small eyeball. Cornea plana. This is a rare condition which occurs since birth, where the cornea is absolutely flat, comparatively flat, and cornea plana usually results in marked astigmatism refractive error. Anomalies of corneal transparency. The normal cornea is usually transparent, and some of the congenital anomalies are listed below. Anterior embryotone, it is a broad limbus typically superiorly. Posterior embryotoxon, thickened, anterior displaced as Schwartz line. Congenital corneal opacity can occur alone or with the syndrome like lower legier or the pedal anomalies. Sclerocornea, cloudy, sclera-like cornea, may be peripheral or diffuse. Dermoids, round, dome-shaped lesions at the infratemporal limbus and may be usually larger areas of the cornea or the eye. Corneal opacity. Corneal opacity refers to the loss of transparency of the cornea in various conditions. The term corneal opacity specifically denotes the transparency due to the scarring. Congenital opacity. Congenital opacity causes can be defined as trumpet. S stands for sclerocornea, T for tear in deciment membrane, congenital glaucoma or birth trauma, U for ulcer, M for mucopolysaccharidosis, mucolipidosis, and the tyrinosis, P for posterior corneal defects, Peter anomaly and posterior keratoconus, E for endothelial dystrophy, congenital hereditary and posterior polymorphosis, D for dermoid, healed corneal wounds, and healed corneal ulcers. The types of corneal opacities are listed below. Nebular opacity, the opacification is seen in the superficial layers, which causes blurring of vision. Macular opacity, semi-dense opacity, which involves half of the cornea centrostroma. Leukomatous opacity, dense white opacity, and scarring will be more than half of the stroma. Adherent leucoma scarring after the corneal perforation with iris incarceration. Facet, depressed scar due to the less fibrous tissue. Keratosia, increased corneal curvature due to the weak scar. Anterior cephaloma, ectasia of the pseudocornea after total corneous locking with iris. The treatment usually involves optical iridectomy, the removal of iris for the central macula in case of leukomatous opacity of vision improvement and pupillary dilation, and phototherapeutic keratectomy, useful for the superficial corneal using the external laser. Keratoplasty provides good vision, which results in the uncomplicated cases with the cornea, especially when the optical iridectomy isn't useful. Cosmetical, these are color contact lenses. It provides often excellent appearance for the and no vision potential and considered the best option over tattooing. Corneal vascularization. The normal cornea is avascular except for the tiny peripheral capillary loop. Corneal vascularization occurs in response to the disease or injury and reduces the it is caused by chemical and mechanical factors, vasoformative stimulus, and loosening, and promote the vessel tooth. Example due to corneal edema. Superficial vascularization, the vessels and the urbanizing patterns and under the conditions which causes trachoma, phyllotenular keratoconjunctivitis, superficial corneal scars, contact lens wears, and rosacea keratitis. Deep vascularization, vessels and stroma, straight. Common causes involve interstitial keratitis, fusiform keratitis, and deep corneal ulcer burns, and sclerosing keratitis, corneal graft resection. Treatment involve corticosteroids, which reduces the vessel growth and leakage. Irradiation helps in superficial vessels. Surgical peritomy may occur in the superficial cases. Inflammation of the cornea. Inflammation of the cornea, keratitis is characterized by corneal edema, cellular, and the ciliary congestion. Classification. The classification depending upon the topographical ulcerative keratitis, which is corneal ulcer by location central and peripheral, by purulence, suppurative, bacterial or fungal, non-suppurative, viral, chlamydial or allergic, not by hypopyon, simple and hypopyon ulcer, by depth, superficial, deep, impending perforation, perforated, by slogging, and non-slogging. Non-ulcerative keratitis, superficial, diffuse, or the superficial punctate keratitis. In deep, non-separative, interstitial, deciform keratitis, profunda, and sclerosis. Suppurative, central, or posterior corneal abscess. Etiological classification. It can be classified into infective, allergic, trophic, and associated with skin and mucous membrane diseases, systemic collagen vascular disorder, traumatic, and idiopathic. In infective, bacterial, viral, fungal, chlamydal, protozoal, and the spirotal, allergic, phyllotenular, vernal, and atopic, trophic, exposure keratitis, neutrophic, keratomalacia, atheromatous ulcer, and systemic collagen vascular disorder. In traumatic, mechanical, chemical, thermal, radiation-induced, idiopathic, Murine ulcer, superficial limbic keratoconjunctivitis, and Tiger's syndrome. Pathology involved damage to the corneal epithelium, which introduced a microflora to the stroma, and microflora to infect the keratin of the stroma, and then corneal inflammation attracts the neutrophilics to the cornea, and then enzyme is released by the neutrophils, exacerbates inflammatory, and progressive inflammation quick leads to the corneal perforation, and wound healing often leaves scarring. The infectious diseases, risk factors, bacterial, in bacterial contact lenses, dry eyes, abrasion, and Sitlam findings, round, oval, white lesions, AC activity, and clinical features involved in bacterial is hypopyon, and in viral, history of cold sores, branching epithelial defects, dendritic ulcer, and in fungal trauma, vegetative outdoor, infiltrate with the feathery edges, and gray and white lesions. Protozoal contact lenses, poor hygienic, ring-shaped infiltrate, and for the clinical features, ring-shaped infiltrate. Corneal ulcers. Corneal ulcers is a corneal epithelial defect which involving the underlying stroma and is potentially a vision-threatening ocular emergency. It is usually associated with a tissue excavation, infiltration, and necrosis. A corneal ulcer is a corneal epithelium defect involving the underlying stroma and is potentially a vision-threatening ocular emergency. It is usually associated with tissue excavation, infiltration, and necrosis. Etiology. Bacterial risk factors include contact lenses use, trauma, diabetic, prior surgery, and corticosteroids, contaminated meditations, and agriculture. Common pathogens Staphylococcus aureus, Coagulase negative, Staphylococcus pseudomonas aeruginosa. In polymicrobial, Staphylococcus epidermidis, Staphylococcus fusarium. And viral HSV, most common viral cause, which leads to the unilateral infections, corneal blindness, others varicella zoster virus and cytomegalovirus, which is rare. And in fungal, 5 to 10% of cases are more common in the humid climates. Common species includes Aspergillus, Fusarium, Scedosporium, Candida, trigger trauma with a plant and vegetative matter. Protozoan, Acanthamoeba found in a fresh water or soil, seen mostly in contact lens users. Symptoms in bacterial ulcer, present with pain, redness, foreign body sensation, photophobia, tearing, watery discharge, and swelling. In fungal ulcer, may cause blurred vision, redness, lid edema, photophobia, pain, and irritation. Viral ulcer usually lead to the pain, redness, photophobia, blurred vision, and a gritty or sandy feeling in the eye. Signs of bacterial ulcer involve epithelial defect, corneal infiltrate or abscess, corneal melt, descemetosole, perforation, conjunctival congestion and injection, anterior chamber reaction with exudate and hypopyon. Fungal ulcer, gray or white stromal, full thickness infiltrate with the indistinct or feathery margin, satellite lesions, conjunctival congestion and hypopyon. Viral ulcer, dendritic or the jog epithelial lesions, subepithelial keratitis, stromal haze or infiltrate, interstitial deciform keratitis, corneal thinning, vascularization, reduced corneal sensation, and conjunctival congestion. Treatment for the bacterial, topical fluoroquinolones, culture large central ulcer, and post-centriaxone for the gonococcal cases, systemic antibiotics for the severe cases, and corticosteroids for only under the specialty care. In viral, topical antiviral like trifluridine and acyclovir, oral antivirus acyclovir and valaciclovir, and the ganciclovir, valganciclovir for the CMV, monitor side effects. In fungal natamycin, amphotericin B, and the voriconazole. In Acanthamoeba, epithelial debridement, antiamoebic therapy for 3 to 4 months. And in case of autoimmune, systemic immunosuppressant is given and it is co-management by the ophthalmologist or the rheumatologist. Documentations of clinical signs, uses of the color-coded diagram with lesions dimensions for monitoring, and high-quality slit-lamp photos may supplement or replace drawing. For the scars and degeneration, black is represented, and for epithelial edema, stromal edema, decimal fold, blue circle shading or wavy lines, and for the hypopyon, yellow is indicated, and for vessels, the superficial wavy from outside limbus and deep straight from limbus, red is indicated, and for the pigmented lesion, example, iron lice, Glutenberg spindles, brown is indicated. This is the color coding of documentation in cornea. So I said green for the epithelial defect and blue for the stromal edema, blue circle for the epithelial edema, yellow for the infiltrate, gray for the corneal scars, and red complete lines represented blood vessels, red dotted lines represent ghost vessels, yellow for the keratic precipitate, and brown for the pigments on endothelium. Corneal dystrophies. Corneal dystrophies are inherited, bilateral, non-inflammatory, and non-vascular corneal disorders that often appear in the first or second decade, sometimes at birth or later. They occur without systemic disease and usually lead to the corneal haze in otherwise normal eyes. These are some of the corneal dystrophies and mode of inheritance for the EBMD, autosomal dominant in mode of inheritance. Age of onset is variable and map dot or the fingerprints as patterns. Treatment BSCL and hypotonic, Shatish, PTK, and ASP. And the Meesman autosomal dominant first decade, epithelial microcyst, BSCL, and keratoplasty. And for the Bowman's, Reese Buckler's autosomal dominant first decade, subepithelial reticular opacification, and BSCL and keratoplasty. Stromal, granular, autosomal dominant first or second decade, gray or the white opacities, BSCL and keratoplasty. For the macula, mode of inheritance is autosomal recessive. Age of onset is first decade. Pattern hazy stromal opacification. Treatment includes BSCL and the keratoplasty. Lattice mode of inheritance is autosomal dominant. Age of onset is first decade. Pattern refractive branching lines and treatment is BSCL keratoplasty. And TPD mode of inheritance is autosomal dominant. Age of onset is first decade. Pattern vesicular lesions of posterior cornea, and for treatment, BSCL, hypertonic, and the keratoplasty. And for the first mode of inheritance is autosomal dominant, and age of onset is fourth or first decade, fifth decade. Pattern is gutata or the corneal edema, and treatment involves BSCL, hypertonics, BSAEK, and the keratoplasty. Corneal ectasia, keratoconus. Keratoconus is a progressive non-inflammatory bilateral 85% of the ectatic condition of the cornea in its axial path. It usually starts at puberty and progresses slowly. Symptoms involve defective vision from the progressive myopia and irregular astigmatism, which cannot be corrected with the glasses and soft contact lenses, blurred vision, glare, halos, light sensitivity, and irritation. Vision loss occurs mainly due to the astigmatism and myopia, and secondarily from the cornea scarring. Signs involve stromal thinning with apical protrusion and irregular astigmatism. Distorted reflexes and preciously walk striae are seen in the slit lamp examination. Munson signs can be observed if the patient is looking down and in the later stages, and scissor reflex in retinoscopy. Keratometry is scissor reflex is seen in retinoscopy. Keratometry values increase. Topographic defect early from first stage. Complications involves the acute hydrops will be a student stroma due to the rupture of the descendant membrane. So this causes development of corneal edema, which is associated with the defective vision, pain, photophobia, and lacrimation. Treatment includes glasses, RGB lenses, rose case leader lenses, intact corneal cross-linking, and keratoplasty in advanced stages. Keratoglobus. It is a familiar and a hereditary bilateral congenital disorder, which is characterized by thinning and the hemispherical protrusion of the entire cornea. It is a non-progressive, inherited as an autosomal recessive trait. It must be differentiated from the congenital ophthalmos, where there is an increased corneal size. It is associated with the raised intraocular pressure, angle anomaly, and or cupping of optic disc. Thank you.
Thank you so much, Nivya. It was an elaborative presentation on corneal diseases. Now I request a moderator to add few inputs for the same, sir.
Good evening. Thank you, Nivya, for such an insightful and comprehensive session on corneal pathologies. Let me start with an interesting fact that the term cornea is derived from a Latin word, which means horn. This is due to its tough and protective nature. I would like to add some points in pathological responses that happens in cornea, because being an optometrist, we should not only know about the clinical features, signs, symptoms, management, diagnosis. We should know what is the pathological response and how it happened and what it is. Even though we are not going to treat most of the corneal pathologists, We should know that the pathological response occurs in cornea because we are the first line warriors for reducing the preventable blindness. Most of the preventable blindness, such as trachoma, is also a corneal diseases. Since cornea is a avascular layer, how it gets infected, how it undergoes dystrophy, how it goes degeneration, thinning happens, these will come under the pathological responses. Usually, based on pathological responses, cornea is divided into 4 zones. The first one is the epithelial zone, and the second one is subepithelial zone, which includes Bowman's and anterior stroma, and the third one is a stromal zone, and the last zone, which includes descendant and endothelial. Usually, there are 6 pathological responses, which I like to add in this session. The first one is defects, the second one is fibrosis and vascularization, third one is edema, fourth one is inflammation and immune responses, fifth one is deposits, and sixth one is proliferation. Most of the corneal diseases that we discussed earlier, which comes under this pathological responses. Let me say, for example, defects, the first pathological responses, which commonly happens mostly post-operative conditions. It occurs in the 4th zone, such as endothelial keratoplasty, DSCK, DMEK, all the defects which comes under the 4th zone. And the common zone that prone to defect is 3rd zone, which is obviously the thinning of stroma, where the corneal shape is thin, which is KCN. And the second pathological response is fibrosis and vascularization, which is usually the fibrosis occurs at the second and fourth layer of the cornea, which is connective tissue layer. This happens most commonly. In this tissue, most of the proliferative and vascularization is beneficial in all other organs, but in eye, mostly in the cornea, it leads to corneal opacity, so it is not a beneficial in the case of corneal pathological responses. And the next third is edema. As we know, edema is most commonly in cellular layer. The cellular layers are epithelial, endothelial, and stromal layers. In these layers is more prone to edema. It may be diffuse edema, as in the case of stromal cells, or focal edema, as in the case of epithelial mycosis. And the next fourth pathological responses, inflammation and immune responses. This we day-to-day we see in a lot of cases such as keratitis. This will fall under this pathological responses. This may due to microtoxins or microorganisms. Usually, the inflammation and immune response occurs in 3 stages. First one, the initiating pathological event. Second is post-immune response, and third one is a repair process. Whatever the repair process is going on, the final outcome is corneal opacity. Next pathological changes is deposits. There are deposits either from external sources or internal sources. Mostly in ocular, we thought that the most common medicine drug which causes deposit is anti-tuberculosis drug. But in case of cornea, the most common deposit is from anti-arithmetic drugs because it forms a circular pattern. It easily passes through the stem cells from the corneal limbus like this. So in case of deposits, anti-arithmetic drug is more common. And the last pathological response is proliferation. This also happens in 3 stages. In case of tumor, the only layer which leads to neoplastic in cornea is epithelium, which varies to squamous cell carcinoma. This squamous cell carcinoma of epithelium is missing in that slide, so I like to add. And also, I would like to thank all the organizing team and Dr. Agarwal Optometry for this second session with me. And also, I would like special thank to Anshika ma'am because I had privilege of learning low vision under her guidance. I really wish to add one thing that ma'am taught me is she introduced me the World Vision Report 2021. This report highlights that nearly 1.1 billion people worldwide were having visual impairments. A significant portion of these cases is corneal pathology, which making our decision today all more the clear. And also, I would like to add one more thing is that October 2024, WHO announced India is glaucoma-free country. It is also a great achievement for India. And we need to do more being an optometrist and young buddies. Wish you to have a happy session. Thank you.
Thank you so much, sir. Thank you so much, sir. It was an extensive inputs on why the pathological changes occur and what is the commonest pathological change, how do we get it, how do we come across various conditions. It is very clearly explained in a short, crisp and summarized manner, sir. There are a few questions from the student side. I would read the questions for you.
Yeah.
First question is, which type of opacities will obstruct the vision?
Whatever the opacity which are in the visual axis, this will obstruct the vision. Other than the null-axial opacities, it may causes some pathological changes, but it not affect the visual acuity.
So thank you so much. The next question is, how do we differentiate keratoconus from the other ectatic disorders like PMD or TMD in clinical settings?
Yeah, for keratoconus nowadays, most advanced the topographies, ORT scan are a lot of available. In that parameters, we need to know what is SINK, SRA, SA, a lot of indexes are there. If we more familiar with that indexes and more familiar with that normative value, we will easily diagnose this. But depends upon the Strickland findings, there are some characteristic features for KCM based on this, we may differentiate.
Thank you so much, sir. The last question is, when would you recommend C3R for keratoconus patients?
Yeah, this is also, we need to know what are the stages of keratoconus. If it is a keratocasian suspect or form first keratoconus, it is not that much value. But if for example, there is a Amsler-Wilmer classification is there, if it is a classification system for keratoconus, if the keratoconus goes to stage 3, for example, if the corneal Skeeper's median goes to 52, they have the certain setup of for the patients who need to support the C3R. If not only the power and also for the thickness, if the thickness is less than 450, likewise, there is a certain criteria for each of the pathological process, and also based on the treatment also is also done.
Thank you so much, sir. And I would like to join with you for thanking Anshi ma'am again. Not only you, it's also me who has got trained from Anshi ma'am. She is the biggest reason for me also for being in this position or to have a vast knowledge about the public health and low vision areas. Thank you, ma'am. And over to Anshi ma'am. Do you have any questions, ma'am?
Hi, that was too much about me. Both of you are only reading to achieve what you all are doing. So I think it was a comprehensive session. She had a lot of information on her slides, and Surya also put up, as you said, in a very crisp manner. So I don't have anything to summarize, but I would just like to thank Surya for giving your time and being to the point so that anybody who wants to use this video or watch this video knows what are the takeaway key points and how we should remember the most important aspects of corneal pathologies. So thank you, Surya. Thank you so much. Over to you, Gomati.
So thank you so much, Anshima. And Surya sir, thank you so much for joining us as today's moderator. Thank you, sir. Thank you so much. And a great presentation, Nivya. Best wishes for you. And dear audiences, the announcement for this week is coming Sunday. We got a contact lens workshop at our college. If you have not registered, please go and register soon. The seats are filling up very faster. And other information is Bachelor's of Optometry course admission has been started at Dr. Agarwal's Institute of Optometry. Look at the description for all the details for joining for the course. If you like this video, give a thumbs up and share with all your friends. Meet you all in the next episode. Thank you, ma'am. Bye, sir. Thank you, sir.
Thank you.
Ready.